As physicians, typically we interrupt a patient within 11 seconds. If we look at studies at how long it would take for somebody to get out the agenda of what they're concerned about, that takes on average 30 seconds.
If you cut in and there was important information, you're going to miss all of that. We had one patient when I was in my training that got admitted for a severe sepsis, but nobody really had a chance to ask about certain social things at home. As this patient was slowly declining, a medical student was talking to the patient's family and found out about them having cats at home and getting scratches. The patient did indeed have cat scratch fever, which needs different antibiotics than what had been given. If you're a patient and you're being questioned and being shut into a certain pathway too quickly, how can we approach that as a patient?
I'm Dr. Laura Sidari, board-certified psychiatrist.
And I'm Dr. Tony Sidari, board-certified rheumatologist.
And welcome to our podcast, No Cure for This, giving you what to say for medicine and life when you have something you can't fix. And all you can do is cope, adapt, laugh, and keep showing up. We're here for the stuff that isn't a guideline. We'll talk about burnout, stress, relationships, and everything in between.
Although our work as physicians informs these discussions, this podcast is not for treatment purposes, and any descriptions of patient situations have been modified to protect confidentiality. For any direct medical advice or treatment needs, we recommend you seek the care of your healthcare provider.
A lot of times in medicine, we give a lot of power to, can I get to the right answer? Somebody has all these terrible life events that lead up to coming to see us maybe as a specialist, and we want to be the one with the answer. And so in medicine, we often glorify that, but oftentimes forget that really one of the most important things of all is just knowing how to ask the right question. So in today's conversation, we're going to talk about what makes a good question, and how do we move forward to get to that answer and do it with a little compassion, warmth, and humility.
It feels good when we can be helpful. It feels good when we understand what's going on, and to be able to have the answer to like what the diagnosis is or what's going on for that person. I think a big reason we rush to answers is because we feel comfortable being in that seat of sharing information. That's what our clinical training focuses on. That is what our medical school training and our clinical practice really centers on, being able to understand the situation and provide some answers. And there's not enough attention paid to what's the question to help us get there.
We need to get a history, use your acronym, get that history about the pain, use what we call old carts. And that's everything from onset, location, duration. This is not a medical lecture. You get through all these things. We're going to get a diagnosis. Then we have a way forward. Here's how we treat it. Or maybe we have more workup to do. Next question, like next patient. Sometimes if we think we know the answer before we've had the chance to gather all the information, we end up down the wrong pathway. For instance, we had one patient when I was in my training that got admitted for a severe sepsis, like bad bacterial infection in the blood. Patient went to the ICU. They were on triple antibiotics, as is standard, especially in that situation. They got blood cultures. Blood cultures are negative. They had some very rote history when the patient first came in through the ER. Granted, they were like really sick, but nobody really had a chance to ask about certain social things at home. And it was about day 3, as this patient was slowly declining, that a medical student was talking to the patient's family and found out about them having cats at home and getting scratches. And it turned out that the patient did indeed have cat scratch fever, which needs special cultures and needed different antibiotics than what had been given. Even though it was very broadly covered, it doesn't cover that particular bacteria. And the patient got better. And it was literally a little piece of history that was unfortunately, in that acute moment, may not have necessarily come up. Like, hey, you got cats? Oh, yeah, I got cats. Let me just sit here and have a severe fever and try to crash while I tell you all about it, As an example of, sometimes we need to ask the questions in a way when we're talking about medical things and in general in real life to help us kind of determine what other questions need to be asked before we jump into, well, here's my answer.
The answer is only as good as those questions that we ask. And we don't realize that until we have situations like what you just described. A lot of times we might learn about it in a soft way, but in that situation, it can make the difference between life or death. When we look at how well we do at asking questions, in general, as physicians, there's room for improvement. So typically, we interrupt a patient within 11 seconds of them starting to speak. But if we look at studies at how long it would take for somebody to typically just get out the agenda of what it is they'd like to talk about or what they're concerned about, that takes on average 30 seconds.
I think most people would be surprised at that too, that, there's almost this unspoken feeling that if you let somebody just talk and spill it all, that they could talk forever. And I agree. In my experience, that's definitely not true. Maybe somebody could go 30 to 60 seconds, but if you cut in on second 11 and there was important information to be had by that end of 30 seconds or 60 seconds where it did finally meander to, this is really important, you're going to miss all of that.
When we think about the answers, they are more attractive because if you get the answer right, it has the key to the solution. However, if we get the question wrong, the answer that we receive ultimately will not be what's needed.
So what makes a question good?
When we're getting started working with somebody, it's really important, especially to start very broad without assumptions. So a good question is going to be open-ended. It's going to have not a leading direction. So it's not going to be, tell me about your pain, tell me about X, Y, and Z. It's going to be more so, what brings you in today? Or what are the things that you'd like to discuss today? So it's a catch-all. It allows for that richness of the story. It allows for that richness of information that we can't get if we're already starting out very focused. The other part is it's going to be non-judgmental. So asked in a way, not just the words that we use, but the way that we say it. So what brings you in today versus what brings you in today? That interest in understanding, that interest in hearing the answer. The way that we say it also is about the eye contact that we give in our body language. So if we're asking the question while starting to type already in our computer, looking away from the patient, that's going to also cause a communication of, I don't want to know much information. I just want to cut to my part of the talking or my part of the information.
I kind of liken it to when I'm chatting with a patient, it's really not much different from that perspective as if, say, you were a cast member on, a stage in a theater. The patient is your audience, and everything I do is going to be centered in that direction. It's part of that. Like when I'm going to ask a question, I'm looking at them. I'm not looking down. I'm definitely not looking away. I mean, I could be washing my hands with my back turned, and I'll still turn around to at least be able to see them while I'm doing that if I'm asking them questions and talking to them during that time. And agreed with what you mentioned about there's a lot that can be perceived in the cadence of your question, the how pressured your speech is while you're asking the question. Also, if you don't seem like you care while you're asking the question, there's a lot of variance. And I think that it's much more than just how you ask it, but then also where does it go from there? So when people ask the open-ended question, where are pitfalls that you might fall into subsequent to getting that answer?
Let the patient fully answer. There can be this feeling, though, like I need to get to that next step. I need to jump right in if I'm going to be able to get to the answer or get to the next step, or I have 5 minutes before I got to get in. However, you're actually creating inefficiency when you're doing that. You're not getting that same richness of information. So some of the pitfalls that we can really fall into are anchoring bias, where the first thing that the patient says or the very early thing that they're saying, we then think is actually important.
Anchoring bias is absolutely fatal in that interaction because it will prevent you from continuing to keep your questioning broad. And essentially, you may not yet know what is most important, but you've already anchored on this small tidbit of information. And now all this other information that you'll never know because the patient didn't realize it was important. They didn't know it was not something normal maybe that they were experiencing. And you'll never know that information either. You'll get to the wrong answer. Other types of bias, like confirmation bias, thoughts on that?
With both of these, they can occur for the patient as well as for the provider. So sometimes as patients, we might be gathering a lot of this information that we have ahead. We really think that this is what is going on for our symptoms. And so then we come in and all of the questions that we're asking or all the information we're gathering is to confirm a conclusion we've already come to. A good question is going to cast a wide net to gather high quality information, and then we come to our conclusion from that information. But with confirmation bias, we've already come to our conclusion. And so all the information that we see or that we gather is just to prove that. And this is where we see a lot of challenges come up, let's say, for misinformation, where we're concerned about safety of certain treatments or we're concerned about what certain symptoms mean. The problem is that it is not going to actually get us to what's going to help our health and what's going to help us address the reason that we're there today. For patients, it's really a power imbalance when we're coming in. And we've experienced this too. Even as doctors, we need to get care. And as patients, it's important that we come in with really high quality questions. What do you think's going on? What are the other conditions that you considered? What are the different treatments? Even though we have this medical background and training, we're not going to be experts, let's say, if we're going in for cancer treatment or we're going in for care from a different specialty. So coming in with that humility in the way that we ask those questions can help us to prevent against confirmation bias where we already have our conclusion made and we're just seeking information to be able to say that is true and you are right. As the patient, it's not important that this is exactly what it is. It's for us to find a way forward that's going to help us to get better. It's less about who is actually the holder of the right answers. It's more about us coming together to find what is the best representation of what we're needing.
Yeah, the truth exists somewhere. And if you don't ask those right questions, you just won't ever potentially get there. So we start out with open-ended questioning. Where does it go from there? What's the best process?
The next part then would be going into focused open questions. So these are going to be more directed after we've heard the whole agenda, all of the things that the person has really identified as concerning or important to them, to then get more targeted about what we're seeing as curious or concerning for the reason they're here. So then it might be coming in with, share with me more about what's going on with your stomach, or share with me more about what's going on with your pain, because it allows us to still gather that richness of information, but get a little bit more targeted. How have you noticed as you've been asking questions for your patients that flow from open-ended to more focused tends to occur?
It really depends on what somebody might divulge in the first question. So, for me, in patients coming to see rheumatology, they sometimes don't know why they're coming to see us, and they have as many questions as I do. And then sometimes it may be maybe a very broad question like, tell me about your pain, because their main concern is that they have pain. And they may have it in so many areas that they can't pin it down. And so it can be very helpful, like in that setting, to go bit by bit and say, well, we didn't really talk about your back. Why don't you tell me about that? Or why don't you tell me about the shoulder? It seems to be bugging you as we're sitting here. Just paying attention to context even in that scenario. And then sort of similarly, I think there's certain ways of how we follow on to the answers that can actually maybe elicit better responses. So for instance, if I ask an open-ended question and you tell me, okay, yeah, my shoulder's really been bothering me, going back to anchoring bias, it would be a fatal flaw to say, oh, you have shoulder impingement. Okay, well, let's have you do X, Y, Z. Didn't ask a single other question. That's just, you might be right, you might be wrong. Maybe a better approach would be, one thing I like to do, I might ask a question using what they told me. So my shoulder's really been bugging me. Shoulder's been bugging you. May just reflect back a question. Oh yeah, it's been bugging me since I did certain injury to it like 3 weeks ago. I'm actually eliciting more information. I'm not even trying that hard. It's literally just reflecting back what the person said to me. This is like a known technique. It's non-judgmental. They know I listened. They know I heard them. And they know I'm interested because I'm reflecting that back. I'm not just jumping to conclusions. There's data even on just simple acknowledgement. Even the old, anything like that can be an acknowledgement. You're telling somebody like, I'm listening to you, but my favorite is always reflecting back and trying to find ways to, if I can, in my own words, say back what they've already told me.
We've talked about anchoring bias and we've talked about confirmation bias. But that brings us to another kind of bias that can occur when we're jumping in too quickly on that, like, oh, you got that impingement in your shoulder. Premature closure on diagnosis is another one that we can fall into when we're too much focused on in search of the answers as opposed to asking the effective questions. So if somebody is sharing some information, like I'm having this burning sensation, jumping straight to a singular diagnosis can be a tendency that we would have with an illness-focused approach. A better way to go about that, especially in fields like ours, where it's very much looking for end-stage symptoms and it's a constellation, a collection, is really looking at this metacognition approach. So what this means is instead of jumping to an illness-specific approach, we're keeping our differential diagnosis of what this could be really wide and letting the information that the patient shares with us to help tick off that list what it's unlikely to be. So instead of jumping into straight, like, this is what I think it is.
One issue that arises is if you funnel down too quickly. So if you go from very open-ended to now I'm kind of close open-ended, like a little more specific. Now I'm going to ask you some very particulars and then, hey, I'm done. I got all my answers. Versus you may ask an open-ended question, get some information. You might start closing it down. Like, okay, we're getting some specifics on this burning that you're describing in your legs. Now instead of pinning it down to some very discrete facts, maybe I'm asking more open-ended questions. So it's almost this cyclical kind of thing where it's open and then it's a little more closed. Oh, I got more information. I need to go back to an open-ended question again to find out some more variables. And I liken it to, maybe this is like a fantastical definition of what we do, but I really liken it to a detective collecting evidence. I have these little Venn diagrams in my mind of overlapping, competing possibilities of what is happening or what could be connected or not. And I'm going to have to go through this flow of finding out information to sort of see what connects, to see what is the timeline. I guess I visualize it like an iMovie timeline, like when did things start and what was all the action throughout the movie. And if you don't know bits of the movie, you're missing out on some of the point. And the big deal is there's a place for those pointed, very closed-ended questions, but that can come at the very end. That can come at the very end of the whole thing as you've collected every bit of information. And then I think issue number 2 is if you close down too quickly, you'll get to the very, and everybody who has, worked in medical practice has experienced this, I'm sure, at least once, and if they say they haven't, they're lying, is you get to the end of a nice 20, 30-minute appointment, you think you covered it all because you had the answer and it was perfect. And then the patient says, oh yeah, there's something else I wanted to tell you. It's like, you didn't even get to the point. Actually, you didn't even get to what they wanted to talk about. You just kind of jumped in and made all these assumptions.
One of those strategies we can do to go from that open-ended to focused to open-ended is asking that bridging question proactively of what else? Asking what else proactively allows for us to gather that additional information early and often to then make sure we're incorporating that into the information we're gathering. When do you notice that really pointed, close-ended questions can be helpful?
I'll give you an example. Like, let's say somebody's referred to us for a very particular question, and I make it a point to not just approach that, say, consultation with somebody walks in and I've reviewed the chart and I kind of know everything that they were complaining about, and just like come in and say, oh, well, I don't think you have lupus. Like, this is really going to be a waste of your time. I mean, I go through, what are all your concerns? What were the concerns in context that got you tested in the first place? Because context is king, especially in my field of rheumatology. We get to the end of all our conversating, and I have a good feel for, is this person having mechanical issues like normal joint pains? Is their fatigue more of, an organic thing? Like there's many causes of fatigue that are not rheumatologic disease, as you know, like working in behavioral health. But at the very end, I've gotten through all the history. I need to prove to myself and within the chart and to the universe with some very pertinent questions, pertinent negatives that we would call them. So for instance, if a patient has an ANA test that's positive, an anti-nuclear antibody test that's for lupus, typically, and others, there's some very important questions, what we call review systems, that I have to ask. And other things maybe that are pertinent to what the patient told me that nobody's even thought of. I have to ask these questions. Usually because I'm in rheumatology, I preference these questions by saying, I'm going to ask you some really weird questions. And it's probably stuff you've never thought about, but if you have, it's actually really important. And then I'll go through my spiel of, have you had severe high fevers, 102, 104 degrees Fahrenheit, lasting 2 to 3 weeks at a time? People say, no. It's like, well, that's good. Next question. And I literally will go through my review of systems very pointedly. There's purpose to every question. Little would the receiver have said question no. If that answer is yes, I have to revert back to being more open-ended and say, oh, well, tell me about that. Like, when did you first notice that? Or how does that show up for you? Or there's different ways I will now meander back into the cycle of open and close-ended because I need more information.
I look at those close-ended questions like surgical precision. Like, we've gotten to a point where it's this, or we're wanting to rule something out. And so reserving it for, really, there's only 2 pathways, one or the other. That's where those close-ended questions can be really good. When we've already come to a decision, but we maybe have a few different options about how we actualize that. Like, we're going to be prescribing this medication. Would it be this pharmacy or this pharmacy that would be best? Because you've shared both. Those close-ended questions can be helpful in those distinct situations, but we often use them too often in medicine where we think we're going to get right to the answer much more quickly. How do we also see for patients asking effective questions in medical encounters? What sort of questions do patients ask us that can be really helpful?
I think, knowing that as a patient, it's really important, and us as medical providers, knowing that this is important. It's important in setting the agenda, like, these are the things that concern me, or this is what I'm afraid about that might be going on. I think even before you get to questions, it can be helpful to set that agenda so we know, as we're going through that set of questioning, like, what do I need to be paying attention to that I can relay back to this person at the end? What have I discovered just by talking to them? I mean, 70 to 80% of diagnosis is made by history, in a sense, confirmed maybe with exam and imaging and lab studies and all the above, but most of it's what people tell us. And so I think just knowing that going in as a patient is really, really helpful. But then knowing in terms of questions that you might have for the provider practitioner that you're seeing, it's like, how do I not anchor myself on what I'm worried about and what I think is going on, and give deference to the fact this person's going to ask me questions that, might seem kind of bland or open-ended, and you've lived the experience. So, like, you can take that for granted, but it's really your perception is so important about what's going on with that experience.
We've talked about around the questions, all the communicating that matters, because the words that we use are important, but they're not as important as everything around that. And as patients, that's really important too. So if we're coming in and let's say we've got a lot of mistrust for healthcare, we've got a lot of concerns about how we've been treated in the past, that can show up in the way that we ask questions. Like, are you really sure about that? Or did you even consider that? That's much different than what else? Or did you consider this? The way that we ask the question in a non-shameful, non-judgmental way is just as important as patients as it is as providers and physicians.
What about in the scenario if you're a patient and say you're experiencing that you think you're being questioned and being shut into a certain pathway too quickly? Like, I feel like there's more information I want to give. How can we approach that as a patient?
Sharing that really directly with I statements of, I'm concerned we might not have considered all the possibilities, as opposed to, I'm concerned you didn't do your job, or those sort of statements can be very helpful. And then asking those questions about what other diagnoses could look like this, or what led you to come up with this conclusion. Asking that in a non-judgmental, open way of wanting to understand is very important. And sharing your concerns about that too. I'm concerned that if this is not the diagnosis, I might be harmed. What else could have caused this? I would say the other thing as patients is recognizing it is a really vulnerable place. So I think about, like, for you and me, we do not have expertise in things like plumbing and things like what electricians do. And so we could go to YouTube
Absolutely.
and we could look up how to replace an outlet or how to fix certain areas of plumbing.
But we might burn the house down.
Or, know just enough to get ourselves into trouble. So I think about having someone who's an expert in plumbing coming to our house. They have certification, they have experience. While it could be helpful to share, this is sort of what I saw on YouTube, it would be misguided to confuse that for knowing more than what they know. So when we come to the table, I think both as patients as well as physicians, we need to have that humility that the patient is the expert in their lived experience. They have all of that information we need to understand about their story and narrative. And that is really what matters more than the answer itself. And then as the patient, it is really vulnerable to come in and be in search of these answers and this information, wanting to share what we have, but also recognizing we might not understand the questions that are needed to get to ultimately the most important answer. So I think it's that balance between the two of understanding, looking to one another as an expert, as opposed to one above and one below. And ultimately, we're aligning on what is going to help us come to a better quality of life, a better functioning and understanding of what's going on, and an understanding of what we can do about it.
If you enjoyed being part of this conversation, be sure to like, subscribe, and give us a follow. If you have any questions, topics for future episodes, or a no-cure moment of your own, be sure to leave them in the comments. Thanks for listening, and see you next time.